Now, I would like to begin our next session, Symposium on Esophageal Motility. For this session, I would like to call our moderators on stage, Dr. Ashish Kumar, Dr. Piyush Upadhyay, and our chairpersons, Dr. Shankar Zawar, Dr. Amit Basnotra, Dr. Aval Sadikot, and Dr. Sujay Kulkarni. Please sir, have a stage.
Good morning, ladies and gentlemen. So we begin our symposium on esophageal motility, and for this we invite our speaker, Dr. Jeff Hubbard, who is the Director of Gastroenterology and Hepatology at the Royal Melbourne Hospital, Australia, and he would be talking about basics of high-resolution esophageal manometry and its metrics. So over to Dr. Jeff Hubbard.
So thank you very much for asking me to talk. It's a very hard show to follow with Professor Ghoshal in his wonderful talk. So I'm going to talk about the basics of high-resolution esophageal manometry and its metrics. I'm going to briefly talk about the purpose of esophageal manometry, how we perform it, and then about the metrics or measurements that we derive from the raw study data. A little bit about how we combine them into the algorithm, trying not to step on Shobna's toes, and then recognising when extra information is required and putting it all into a clinical context in the end. So of course we all recognise that the purpose of esophageal manometry is to answer the clinical question whether this is an explanation for the patient's symptoms and some treatment, or perhaps an assessment prior to surgery. And the Chicago 4 classification is what we sort of hang our hats on. And this is used to define the recording protocol, the metrics themselves, and then how they're combined into a diagnostic algorithm. And one of the things that Chicago 4 has done is really to emphasise that the correlation between symptoms and manometric findings is an important part of interpreting the study. So you have to have a match between the two. And it also recognises that there is uncertainty, that there are some findings that are indeterminate that need more information before we can provide advice to the referring doctor and the patient. We do have to remember that it's not validated in the post-operative state. That doesn't stop us using it. And there are some developments as to what normal and pathological states look like. And finally, seeing as Chicago is so well known for its architecture, you're going to have some pictures of some famous Chicago architecture on the right-hand side of the screen as we go through. So when we're performing esophageal manometry, the first step, of course, is to set up the recording system itself. We then perform the manometry, and this is divided into an assessment of the basal LOS pressure and anatomy, some water swallows in a primary and secondary position, and then an optional series of extra or provocative tests to try to clarify any ambiguities in the recording or clinical questions. We then analyse the study, looking at the metrics for the individual swallows, combining them into an algorithm and adding in the results of any extra tests. And finally, we contextualise it into the question that we're being asked and provide a report. Now, there are a number of recording systems available, but basically they fall into two groups, the water perfused and the solid state. In the water perfused, the transducers are external to the catheter itself and connected via some low compliance tubing. And in the solid state, the transducers are intrinsic to the catheter. And each of these systems has benefits and disadvantages. And I'm not going to go through those in detail, but in the end, they're both aiming to measure pressure. Then, of course, you need some electronics, a computer and some software to display and record your data, and then later to analyse and report it. So if we turn to the analysis, what we have to remember is that we're collecting physiological information, or perhaps pathophysiological information from the esophagus. And the things that we would like to know is, firstly, how well does the LOS relax, or perhaps even after it's relaxed, how well does it distend? And here we can look at the integrated relaxation pressure, which we standardly measure in the wet swallows, but we can also use the same metrics to assess LOS relaxation during some of the special tests. We'd like to know about the strength of peristalsis, and this is measured by the distal contractile integral, which really measures the volume under the pressure, time, distance curve. And again, this is measured typically during the wet swallows, but the distal contractile integral can also be used when assessing swallows done in some of the special tests, such as the solid swallows. We use it in the multiple rapid swallows or the solid meal test. But it's the same metric. And finally, we'd like to look at the coordination of peristalsis, although this is probably actually the duration of inhibition of the esophageal body. And this is measured by the distal latency. So if we turn first to LOS relaxation, as we mentioned, this is the integrated relaxation pressure. And this is the mean of the lowest 4 seconds of pressure during the swallow, and it's measured in millimetres of mercury. We do have to remember that the lower esophageal sphincter is a mobile structure, and so we have to place a cursor above and below where we expect the LOS to be, and we take the highest pressure between the cursors as being the pressure of the LOS. And there are a variety of normal values which depend on position and recording system, but the most commonly quoted is 15. But well, again, we have to remember that this isn't a sharp cutoff. It becomes progressively more abnormal as pressures rise, and we certainly recognise there are patients who clearly have achalasia who have a pressure less than 15, and we have to always be aware of artefacts. Now, if we want to assess LOS relaxation in a bit more detail, we can do multiple swallows. So this provides a more sustained stimulus to relaxation, and we can do this within the multiple rapid swallows and also the rapid drink challenge. Alternatively, we can provide some extra stress to the LOS. So in the rapid drink challenge, we're providing a higher volume that has to go through the LOS, or we might increase the viscosity, and solid swallows is the main way we do this. So we're stressing the lower esophageal sphincter to try to bring out abnormalities. So one of the problems we have with an IRP is, well, how do we interpret an elevated IRP? And the first question is always, well, could it be an artefact? And we know that there are positional artefacts that, particularly in the supine position, there can be compression from surrounding structures. Or could it be mechanical? Could there be an esophageal stricture there? Could there be something like a paraesophageal hernia or some extrinsic compression? And what we're going to do is we're going to say, well, is there some supportive evidence of obstruction? So we can look at the intrabolus pressure, which I'll talk about in a minute, above the LOS. We can look at stressing the LOS with the rapid drink challenge. We can look for delayed transit on barium swallow, or perhaps some mechanical analysis, such as with a flip. So we're going to turn to some of our extra tests. And of course, we want the patient to have some consistent or suggestive symptoms. Another issue might be, well, the patient has a normal IRP. Is that really the case? And we'd say, well, the patient has consistent symptoms, but they have a normal IRP. Is their relaxation really normal? Or perhaps there are indeterminate findings. So the patient has aperistalsis, but the IRP is measured on the wet swallows as falling in the normal range. And this is where we might stress the system using our solid swallows, perhaps our rapid drink challenge or our solid meal, to try to bring out an abnormality that may not have been evident on the standard part of the study. And then we can look, is there other evidence of obstruction of delayed transit or mechanical. Another metric is the contraction strength. So this is the distal contractile integral. And this is a measure of esophageal contraction strength, as I said, the volume under the pressure time distance curve. And the integral it defines the level of esophageal contractile strength. So less than 100 we say failed, 100 to 450 weak. They're quite a wide range of normal, and then above 8,000 clearly abnormal, and that can be including the LOS or not. We have to exclude things like coughing and straining, which can artificially change which cause pressures that are not due to the contraction. And also to remember that you can have a contraction that has a normal distal contractile integral, but is not normally sequenced. So it can be rapidly conducted. We can also have contractions that are deficient focally, so we can have breaks in the contraction. And in Chicago 4, these have been combined with the weak contractions into ineffective peristalsis. And finally, we might like to know about, well, if the esophagus has to contract, can it? So this is called peristaltic reserve. And here we're looking to see essentially what is the best contraction that the esophagus can do. And this may be seen after a series of swallows, such as in the rapid swallow or rapid drink test, or if we ask the esophagus to do more work by pushing solids down. When we're looking at the coordination of peristalsis, we're looking at distal latency. So this is a measure of the rate of contraction of the pressure wave down the whole esophagus, but probably relates to the duration of inhibition of the esophageal body by nitric oxide. And where this is measured from the initiation of the swallow to the contractile deceleration point. And this is the point at which the rate of propagation of the contraction slows above the LOS. And it's about 3 centimetres above where we measure the LOS. One problem is that it can be difficult to define. So particularly where we have failed or weak contractions or raised intrabolus pressures, it can be difficult to define exactly where the contractile deceleration point is. And again, we have normal values for that. And the distal latency is used to define distal esophageal spasm and also type 3 achalasia, both of which have more than 20% of swallows with an abnormal distal latency. Again, it can't assess segmental abnormalities. So intrabolus pressure is the pressure between a contraction and the LOS. And we recognise this by vertical stripes of equal pressure within the bolus. Because the lumen is closed above, there's a resistance below, and hence there's pressurisation of a common cavity of fluid. The pressure is distributed equally, so because the pressure is a colour, it's the same colour. And the pressure changes over time, which creates the appearance of stripes. And really, we use this to provide an indirect measure of resistance distal to the bolus itself. And here I've given an example. So here we have the contact pressure from the peristalsis, and this is the intrabolus pressure. And you can see the vertical stripes, which is how we recognise that. Okay, now all of these metrics vary depending to some extent on the recording system and also on the position and also on the population studied. And you're very fortunate in India in having a set of normative values for perfusion manometry. I don't really have time to go into these in detail, but just to let you know that they exist, and you can have a look and see. Many of them are similar, but some are significantly different to the published values. In terms of our extra or provocative tests, we have our solid swallows or our solid test meal. And again, this uses the same metrics, and we're trying to measure the same things, but in a different way to get extra information. We have multiple rapid swallows and the rapid drink challenge. And these are all designed to stress the system or measure or provide different aspects to the metrics, or we can watch things in the postprandial period. So if we look at our LOS barrier function, now this isn't within the, this is in the protocol, but not in the algorithm. And here we have metrics that measure the overall function, so the EGJ contractile integral, the resting pressure, and the morphology, so the size of the hernia and the site of the pressure inversion point. Okay, so we're then going to apply the algorithm based on our physiological information. And I'm running out of time a little bit. I'll just very briefly go through the algorithm. So we have our abnormal median IRP, and if our swallows are all either failed or premature, we're in the disorders of EGJ outflow pathway. If the swallows aren't all failed or premature, we're going to check in the secondary position. And if there's evidence of obstruction, then we'll go to the EGJ outflow obstruction. Whereas if our median IRP is normal, we're looking at disorders of peristalsis based on the DCI. And if there's no evidence of an disorder of peristalsis, we're going to consider some other tests such as the meal tests. So then the question is, well, where do all of our metrics fit in? And you can see here, this is where the IRP and LOS relaxation metrics fit in, where the DCI metrics fit in, where the distal latency fit in, where the intrabolus pressure fits in, and where the extra tests fit in. And what I'm showing you there is just that these metrics are used in many places within the algorithm. So to summarise, the Chicago classification defines a protocol, a metrics, and a diagnostic algorithm for performing and interpreting high-resolution manometry. There are a number of different technologies and systems available, and the metrics correlate with physiologically and clinically relevant aspects of esophageal function. A number of ancillary tests can be used to define further aspects of function or for clinical correlation. And the diagnosis that we base on the algorithmic result, we refine using the information from the ancillary tests, and then put that into context based on the clinical question being posed by the referring doctor and the patient, so that we can answer their clinical question. Thank you.
So that was a wonderful talk on the HREM manometry and diagnostic algorithm. Thank you, sir. Next, I welcome on to the questions we will take at the end of the session. Thanks. Next, I welcome on the stage Dr. Shobna Bhatia, ma'am. She needs no further introduction as she has already been given a Roman introduction in the presidential lecture by Dr. Ghoshal. Welcome, ma'am. She will be speaking on Chicago 4.
So good morning, everyone. And my talk is going to be on finding out whether Chicago 4 is the standard of care in looking at patients with esophageal functional disorders. So just before I start, a quick question to all of you all. How many of you will go to the tax site and pay 30% tax as soon as it pops up and says pay 30%? That is the standard of care. How many of you will go there and say, okay, I'm paying 30% of my salary as tax? None of you? How many of you will go to a CA and say, okay, calculate my tax for me? Very good. So most of you will take help of other things. Same way in Chicago 4, we have the standard document and we have about 5 or 6 other documents which describe each disorder, and therefore you have to go into each of them before you make a diagnosis. So this slide has already been shown, and you can see that Dr. Ghoshal is also onto this. So this is the evolution of the Chicago classification, started way back in 2009, and in 2020 many changes were made. What is important is that the Chicago protocol is only meant for adults. The same protocol has different values when you look at children, when you look at patients who have been operated, as well as patients where you need an upper sphincter analysis. This is not validated for that. Secondly, the Chicago original classification does not include impedance manometry, impedance in its analysis, and therefore I will not touch on that. So this is the protocol. Dr. Hebert has already covered it, and we have the initial adaptation, 3 deep breaths to check that the catheter is in the stomach. There's a baseline. 10 water swallows of 5 ml is what the original classification defined. There are people like Dr. Ravi Mittal, who's in the audience, who always gives only 10 ml swallows for a reason. He'll tell us that. And whenever you want to do impedance or you're doing solid state manometry, do not use water, do use 0.5 normal saline. During the lying down position, when you're doing the swallows, also do the multiple rapid swallows. In the upright position, same thing, repeat the adaptation and 3 deep breaths, do the baseline, do a rapid drink challenge with 200 ml of water or saline as required. In addition, you may do other provocative tests as Dr. Hebert just described for us. So these are the metrics, and this is what the swallow looks like. You look at the relaxation, esophageal peristalsis, deglutitive inhibition, which is the distal latency, and the pressurization, which is the isobaric contour. So in the Chicago 4, we first look at the IRP, whether it is elevated or not elevated, and then look at if the IRP is elevated. In that case, look at the peristalsis. If there is no peristalsis in all the swallows, call it achalasia. Isn't that very simple? But no, it's not that simple. So first, look at whether this is the normal. The first one is the normal. The second one is showing us there is an impaired LES relaxation, but there's absent body peristalsis as well as no pressurization. In the third one, you can see that there is a bolus pressurization here, exactly starting from the upper sphincter, going down to the lower sphincter. And you say that this is a pan-esophageal pressurization, which is associated with an impaired LES relaxation. So therefore, this becomes a type 2 achalasia. In the type 3, there is also premature contractions, as well as lack of peristalsis and an elevated IRP. However, if you do a barium swallow in some of these patients, in most of these patients, you will get a sigmoid esophagus. In some of these patients, you might get a normal barium swallow as well. So in some patients where the IRP is normal, what do you do? That is the thing that Chicago 4 has introduced. If the IRP is normal, do a timed barium esophagogram. Look at the barium level at 0, 1, and 5 minutes. And if at 5 minutes you still find that there is barium in the esophagus, it means that there is a significant obstruction. And even in the presence of a normal IRP, you will still diagnose it as achalasia in a given situation. So in a patient with inconclusive achalasia, I said first, do a barium, do a rapid drink challenge. In the rapid drink challenge, it challenges the esophagus, and when there's a large volume in the esophagus, the LES does not relax well, and that tells us that there is evidence of obstruction, and you can diagnose an achalasia here. The next thing that we diagnose in a patient where the IRP is abnormal is what you would call as an EGJ outlet obstruction, outflow obstruction, where the IRP is abnormal, but the peristalsis is absolutely present. When you do this procedure in the lying down position, about 10 to 15% of patients will have this abnormality. However, if you challenge these patients, you will find that there are differences that you find. So IRP is not a dichotomous value, as Dr. Hebert said. So you can't have a pure cutoff. More than 15, call it achalasia or EGJ. Less than 15, call it normal. It's not like that. So if the IRP is higher, there is a higher likelihood that this patient has an abnormality. However, if it's in the borderline, say 16, 17, 18, then start looking at other disorders before labeling it as an abnormal esophageal manometry and going ahead and treating these patients. So look at this study, which this is the group from Northwestern, published in 2019, where they did a liquid barium or a barium tablet in patients with achalasia, not achalasia, sorry, EGJ obstruction. And you see that in the first slide on the top, you find that the IRP in the supine position is 22. When the patient was made to sit up, it was normal. And you see the barium on the right, it's absolutely normal. In the second slide, you see that the supine IRP is 53, upright IRP is also elevated. And this patient turned out to have spasm. You see the barium tablet stuck here. I think the barium is not very clear, but it's stuck here, suggesting that there is an obstruction there. In the third patient, you see that there is a spasm. It's the IRP in the upright position is borderline. This patient actually had thickening of the esophageal wall, but did not have an obvious obstruction in the barium swallow, and therefore this patient was left alone and followed up. So this is important. Many patients with eosinophilic esophagitis will also have this kind of an abnormality. So please do not go and do a poem on these patients. So for the further diagnosis of EGG obstruction, try and change the position, do a provocative test, look at Bolen's transit with impedance, which will come in the further sessions, or do an imaging like a timed barium, maybe a CT, maybe an MRI, or even an EUS. So response to free drinking, you can see in the third slide down, as soon as you give a free drinking, the esophagus shortens, the LES moves up, and you see a whole lot of spasm looking like type 3 achalasia. So if there is an EGG obstruction which you suspect, make sure that you do additional tests before you do anything else. This is a very elegant study done by Aresh Babai, and what they showed is that if you give amyl nitrate in patients who have a true obstruction or a pseudoachalasia or a mechanical obstruction will not respond to amyl nitrate. We don't use amyl nitrate, and this is the only group that continues to use it. So if you have a borderline elevated IRP and a single assessment shows an elevated IRP, first do multiple assessments of the LES physiology, look at the supine IRP as well as the upright, look at intrabolus pressurization, and then look at the symptoms of the patient. The symptoms suggest that this patient has obstructive symptoms. You still go ahead and do supportive tests, maybe a timed barium, maybe a flip, and even an EUS, as I will just show in one patient. So this is a 58-year-old man, which I saw about 15, 20 years ago, who had dysphagia only for 6 months, and he had mild weight loss. This is the barium swallow. Endoscopy by a very senior gastroenterologist said, I can't find anything in the mucosa. The manometry at baseline showed a very high LES pressure, that's 160 millimeters of mercury. We were not convinced that this is something. Now, this is long before solid state manometry came. So on the giving the swallows, we saw this spasm, and the highest amplitude that we saw was 333 millimeters of mercury. Got us worried. So what was the odd point? This was a short history. There was weight loss. So therefore, we asked for an EUS, and there was a submucosal lesion sitting there. So we looked at the barium again, and here you see that there is a shouldering effect at the level of the LES, turned out to be a submucosal tumor. So if you have a patient with a short history, please look at additional things before you start saying that this patient has a genuine problem which needs treatment. So after this patient has been studied in the lying down position, put the patient in the upright position and see again where your patient. So if the IRP was abnormal initially, but there was peristalsis, and the IRP improves after sitting up, obviously this patient never had an altered IRP. Now look at the swallows. And one of the disorders of peristalsis that you will see is failed peristalsis, and that will be covered by Dr. Srihari, so I will not be going into that. The next thing is the distal esophageal spasm, where there will be a short latency. So pure distal spasm is quite rare. There's a short latency. You can often see it in patients with opioid abuse, and to ask the patient this history. If the patient has this history, please go back and check your manometry again. And if you have a lot of abnormal swallows, the higher the number of spasms, the higher is the value that you are likely to be, higher the probability that you're likely to be correct. So this is another patient where there is a short distal latency here. The IRP is normal. In another patient, you see that though there is spasm here, immediately after the spasm, there is a second spasm coming up. Many of the patients with achalasia will actually present like this. They will have dysphagia, and over time might progress to pure achalasia. So in the criteria for distal esophageal spasm, you can read the complete technical note, where if there are symptoms, and if you find that there are more than 20% swallows with a short distal latency, in that case you're confident. However, in other cases, please go and do additional tests. In the hypercontractile esophagus, again, this is a disorder that was called as nutcracker by my teacher Don Castell. And here the patterns are heterogeneous. You can find many patterns. The distal latency is normal, but the contractility is high. And here you cautious approach in treating. Very cautiously, because some of these patients may actually have reflux. So if there are clinically relevant symptoms and this fits into a hypercontractile esophagus where the amplitude is really very high, distal latency is normal, call it hypercontractile. But before that, please check whether this patient has reflux and treat them accordingly. Ineffective esophageal motility, Dr. Srihari will be doing. So what are the adjunctive tests? Dr. Hebart did mention some of these. Do a multiple rapid swallow. So what is a multiple rapid swallow? Ask these patients to have multiple swallows, 2 ml, very rapidly, and total of 5 multiple rapid swallows. So this is usually done in hypermotility disorders prior to anti-reflux surgery to check whether there is a peristaltic reserve. But this can also be checked in patients with achalasia as well as in patients with diffuse spasm or distal spasm, where you can see that there is a lack of inhibitory function and the patient will have an additional contraction there. The other thing to do is change the bolus volume. If you change the bolus volume, that is when you really challenge the esophagus. Because if you challenge the esophagus, there are certain obstructive patterns which you will see, and that will tell us whether there is a true obstruction or the EGJ obstruction that you found is really not there. Secondly, in patients with achalasia with a normal IRP, this is a very useful test. As you can see here, this patient eventually turned out to have achalasia. The last thing that I want to cover is a leg raise test in gastroesophageal reflux. This is a new test that's come up. Ask the patient to raise the leg and see whether the esophageal body pressurization increases or not. So if the LES pressure is normal and intact, or the hiatus is intact, in that case the pressure will actually rise and there will be no increase in pressurization in the esophageal body, telling us that this patient has a competent LES. This has come up from the Italian group, and what they have done recently, this is just published last 2 months ago, the Milan score, which is a manometric diagnosis in patients with reflux, and they've looked at these 3 parameters, looking at patient whether he has ineffective motility, an abnormal SLR, or the EGJ-CI and the EGJ subtype, and come to a score with this. So this is how they score it. You can go back and look at the original article. It is really a fantastic thing. So remember that, and this is especially for the PGs, no classification is absolute. There is never a standard of care. Currently, standard of care is definitely Chicago 4, but don't look at only those 10 swallows, because before you make a diagnosis, don't let a single abnormal value change your diagnosis. Correlate the symptoms, look at the clinical impression, and perform additional tests as necessary. Additional tests are not your weakness, but tell you that there can be additional work that needs to be done on this patient. It is, of course, a standardized manometry reporting, and you can use other tests, as I mentioned. Thank you very much for this opportunity.
Thank you. Now again, questions will be taken at the end of the session. Next, I welcome onto the stage Dr. Srihari, a young dynamic organizing secretary of this event, and he will be speaking on the ineffective esophageal motility and absent peristalsis, when to intervene and what to do.
So very good morning to everybody. I bring greetings from Sir Gangaram Hospital, and I'll be discussing on ineffective esophageal motility and absent peristalsis. Can we intervene and what do we do? So this was one nagging question that we always faced. We used to regularly conduct a lot of manometry workshops, and many participants used to ask, sir, we get ineffective esophageal motility, what do we do with this? So that is when I started reading about this, and this is what I'd like to discuss in the next 15 minutes. So to understand motility, first let's understand the basic principles of esophageal peristalsis. So esophagus, the upper 1/3 is skeletal and the lower 2/3 is smooth muscle. So they behave differently. In the skeletal part, there is a sequential firing which occurs directly from the CNS to the skeletal muscles, and it causes a peristalsis. The smooth muscle part is more complex. Here, it is under neurological control from the CNS, but it has its own local controls. And if you see the innervation in the lower part of the esophagus, there is a gradient. There is a gradient that the relaxation fibers are more as you go down and down. So there is a concept of deglutitive inhibition. That is when you swallow. Initially, there is an inhibition of peristalsis, and later there's a peristalsis which occurs. So because the inhibitory fibers are more in the lower part of esophagus is in a prolonged state of inhibition initially, and the peristalsis propagates because of that. We all feel that the peristalsis is seamless, right? So peristalsis is of two types. One is primary peristalsis, which is swallow initiated, and there is a secondary peristalsis also, which occurs when there is a distension of the esophagus, like when there is an acid reflux. But mind you, peristalsis is not a seamless activity. So there are 4 peristaltic segments of the esophagus that are seen, that are mapped by various studies. So these peristaltic segments we also see in the esophageal manometry graphs. They're labeled as S1, S2, S3, and S4. And there is a lot of morphological and functional difference between these peristaltic segments. The amplitude required to propel the barium, it has been seen that in the distal esophagus, it requires a lot more pressure to propel the food bolus down as compared to the proximal esophagus. So there's a difference between all these segments. Now coming on to ineffective esophageal motility. When we talk of ineffective esophageal motility, you often see graphs like this, where the distal contractile integral is low or it is almost absent. And a combination of this is what we call as ineffective esophageal motility. So there was an excellent paper by Peter Carola's group in 1988, which tried to find the relationship between peristalsis and bolus transit. So on the left, you see the typical manometry graphs. These are line diagrams that you see on here. So here you are seeing the peristaltic wave which is propagating down, and this is the amplitude of peristalsis. In this case, this is around 100 millimeters of mercury. And you see the flow of the barium, that is the bolus. So immediately after a swallow is taken, because of gravity itself, the bolus goes quite down. But it is not able to cross across the ileus, and this is where the peristalsis comes into play. The peristalsis leads this tail of the barium out across the esophagogastric junction. In this case, what is happening, the peristaltic amplitude, if you see in the lower segments, is around 40 millimeters of mercury. It is lower than that. And here what is happening, the barium is getting retained. The food bolus transit is not happening properly. So this is how it was found out that what actually happens in an ineffective esophageal motility. So there is a concept of isobaric contour. Isobaric contour of 20 millimeters of mercury has a lot of significance. Here you are seeing an impedance manometry graph. You see that the peristalsis has an appropriate vigor, and the bolus is passing down on the impedance. There is sometimes you see a peristaltic break. So here the peristalsis is broken, and you see that the impedance is showing us that there is an impaired bolus transit in this case. So if you map this, it was seen that at 20 millimeters of mercury and 5 centimeter defect size, this is the cutoff which gives us the highest value for differentiating abnormal versus normal. So you need a 20 millimeter pressure and a defect size of at least 5 centimeters, which will lead to impairment of the bolus transit. So ineffective esophageal motility has been evolving since all the Chicago classifications. In Chicago 2, small peristaltic breaks, that is 2 to 5 centimeter breaks in the 20 millimeter isobaric contour, large peristaltic breaks, that is more than 5 centimeter breaks, and there was also something called frequent failed peristalsis, that is more than 30% failed contractions with less than 3 centimeter integrity in the 20 centimeter isobaric contour. In Chicago 3, the small peristaltic breaks went away. The frequent failed peristalsis was replaced by an entity called ineffective swallows. So ineffective swallows is when your DCI is less than 450 millimeters of mercury. Chicago 4 has gone a step further, and it is now using ineffective swallows more than 70% to label as ineffective esophageal motility, or you should have failed swallows, that is DCI less than 100 in at least 50% of the swallows. So what causes ineffective esophageal motility? It's a complex phenomenon. We don't have one single reason, but it's an interplay between neural factors, which could be central origin or peripheral origin, or muscle dysfunction because of any primary muscle disorders, or because of GRD or medications, etc., which eventually in unison or together lead to ineffective esophageal motility. So what happens when you have ineffective esophageal motility? A lot of normal people can show IEM-like pattern. In these, usually the people are asymptomatic. But there are two important things that can happen. There can be an abnormal reflux clearance because of ineffective motility, and these patients will present with features of GERD. There can be an abnormal bolus transit because of ineffective motility, and these patients will present with symptoms of dysphagia. So let's talk about normal variants. So ineffective esophageal motility is reported in up to 30% of the patients undergoing esophageal manometry. So that's a significant number. And 17% of normal patients might show patterns of ineffective motility as per the Chicago 3. Mind you, Chicago 4 has become more strict with diagnosing IEM. In GRD, ineffective motility is seen up to 40% of the patients, and it is seen that with higher grades of GRD, like LA grade C or D esophagitis or with Barrett's, the IEM incidence goes on increasing. So, if you talk about the chicken and egg principle, what came first? Does the IEM precede GRD, or does GRD lead to ineffective esophageal motility? This is a question that we always come across. So, two studies showed that the median age of patients who had ineffective esophageal motility but had normal pH values, the mean age in such patients was lower than in patients who had abnormal pH. So, by this, these studies have come to a conclusion that it is probably the ineffective esophageal motility coming first and eventually GRD coming on later. But mind you, these are non-prospective studies, so we are still not very clear on that. The important question, ineffective esophageal motility patient has, and what do you do with the anti-reflux surgery? There was previously a notion that the partial fundoplications are okay, but you should not do a 360 degree fundoplication in such patients. But there are 4 RCTs which have told us that IEM does not predict post fundoplication dysphagia. So what do you do in such cases? So it is here where an important test called multiple rapid swallows help you out. So what happens when you do a multiple rapid swallow? So every time the patient is taking a swallow, there is a phenomenon of deglutitive inhibition, right? So one swallow, deglutitive inhibition, immediately next swallow, again deglutitive inhibition, immediately another swallow, again deglutitive inhibition. So when all these swallows end, there is a rebound augmentation of peristalsis, and this is what we look out for. If you have a good contraction reserve, that is on the left, you see that the DCI at the end of the multiple rapid swallows is good, better than the primary swallow. The contraction reserve is present. But if you see that at the end also there is no good DCI as compared to the primary, the peristaltic reserve is absent. So in such cases, you should not do a 360 degree fundoplication. There was a study by Stephen Hassack's group which found out that absent contraction reserve, the multiple rapid swallow contraction reserve, was the best predictor to tell us patients who will land up with post fundoplication dysphagia. So a very important test to be done. Then comes something called solid swallows and standardized test meal. The problem is that we give liquid swallows 5 ml each, which might not be very representative of what happens in real life. So you can give solid food swallows or standard meal challenge. On the left hand side here, you are seeing single water swallows. This shows solid food swallows, and when you do this, we saw that there was a lot of discordance. The yellows and the blues are the discordance when both these things were checked, and there was only very little concordance. The greens and the purples are the concordant area, so very little concordance when it is done differently. Flip we still don't have in India, but this is likely to help us because it helps us elicit secondary peristalsis. So you can distend the flip device and it leads to secondary peristalsis in the esophagus. Secondary peristalsis is very important because it contributes up to 90% to acid clearance. So we can find out if that is a problem. Impedance again can help us. There is a phenomenon called post-swallow induced peristaltic wave. So an acid reflux leads to a peristaltic wave, and how many peristaltic waves are occurring, that can help us. Mucosal impedance might also help us because if you have GRD, the acid reflux leads to an increase in the intracellular spaces, and there is an easier flow of ions across. So the impedance drops down in such cases. So this might be an early marker for undergoing GRD or chemical changes in the lower esophagus. So ineffective esophageal motility, how do you treat? Seek out for GRD. If there is GRD, this is the only option that we can follow and treat. If there is no GRD, the options are very limited. Prokinetic agents have been tried, but with little success. We still have no clear answers what should be done with this. Then comes absent contractility. Absent contractility is 100% failed peristalsis, that is DCI less than 100 in all the swallows. Now, absent contractility is rarely seen in normal population, unlike ineffective esophageal motility, very, very rare in the normal population. In GRD patients might be seen in around 3 patients. It is very common in connective tissue disorders. A typical is scleroderma, where around 40% of the patients might show absent contractility. The biggest challenge with absent contractility is to differentiate this between type 1 achalasia. You can have patients with type 1 achalasia with lower IRPs, and this is where you have to differentiate whether this is just absent contractility or type 1 achalasia. So 25% of achalasia type 1 and absent contractility can be misdiagnosed using the Chicago classification alone. We have tried adjusting IRPs to lower thresholds up to 10 millimeters, but it is still inadequate to differentiate between the two. So this is where a rapid drink challenge might be useful. As ma'am already discussed, when you do a rapid drink challenge, you are actually stimulating the esophagus more. And on a rapid drink challenge, it is sometimes possible that you can pick up an increase in the IRP, and these are patients with achalasia and not absent peristalsis. It was shown in a study in 2017 that IRP after rapid drink challenge, an IRP of more than 7 is a very good marker for all-cause EGG outflow obstruction, and a rapid drink challenge of IRP of more than 11 has excellent predictive ability to diagnose achalasia as compared to EGG dysfunction. Time barium swallow, we all know, is a good marker, again an additional marker to differentiate between the two. It will tell us about all-cause EGG outflow obstruction, but it might not be able to differentiate between achalasia versus EGG outflow obstruction. Flip topography might help in such cases. So when you do a flip topography, in patients with achalasia, there is a repetitive antegrade and retrograde peristalsis which is seen in achalasia and usually absent in absent contractility. An interesting study which tried using amyl nitrate and cholecystokinin infusions, and it was seen that with amyl nitrate, in a normal patient, there is a relaxation gain that is over and above the normal IRP. There is some gain in the IRP. In normal patients, absent contractility behaves similarly. When you give cholecystokinin, there is an LES relaxation, and absent contractility also behaves similarly. But in achalasia patients, the IRP relaxation gain was much more, and there was also a rebound contraction. Whereas with cholecystokinin, there is a paradoxical LES contraction. So the take-home message is that ineffective esophageal motility is a common HRM diagnosis. Identifying underlying GRD and treating it is the cornerstone of therapy. Absent peristalsis is a very rare entity. Differentiating it from achalasia is an important consideration. And provocative maneuvers in high-resolution manometry are excellent aids in workup of ineffective esophageal motility and absent peristalsis. I take this opportunity to thank all of you on behalf of INMA and Sir Gangaram Hospital. We are just starting and the hall is already full. So thank you so much for being a part of this conference.
Thank you, Dr. Srihari, for that lecture. Now this session is open for discussion. These 3 talks are the basis for all the diagnosis of esophageal motility disorder. So I am sure there would be lots of questions from all the three speakers. So please identify yourself and direct your question to a specific speaker. Yeah.
Hello. Hello.
Yes, yeah, you are
Yeah.
audible.
So there is a positional variation in manometry analysis. Like if we keep patient supine, we will have more of an EGJ outflow obstruction with an high IRP. If we make patient more sitting, then we have more ineffective esophageal motility. So the recent Chicago says that you should take 10 liquid in supine, 10 swallow in supine, and 5 swallow in sitting. So even if we interpret by taking a primary position like 10 supine, we will have more EGJ outflow obstruction. And if we take 10 sitting, we will have more of ineffective esophageal motility. So this 10 plus 5 combination make the Chicago more fallacious. Obviously, ma'am has rightly mentioned that no classification is absolute. But is it the time should we change our protocol by making a 5 plus 5 or 10 plus 10? Like, what's your take on that?
Yeah, I think
Ma'am, would
Professor
you like to
Shobna,
answer?
please.
Yeah. Dr. Jeff,
Can you please?
you can come to the dais.
Yeah, please.
Yeah.
Yes, I think that's a good point. I think you have to remember that as we've seen, the Chicago protocol is in evolution. There are many things that influence values, and it has to be put into context. And that's why it's important that we don't hang our hats on one metric that we need. It needs to be in the clinical context of the patient. And if there are things that don't fit, then we need to think again and maybe do some other studies to try to work out what the significance of that of those is. But I think I think to define normal values for all systems, all positions, all ages, all races, you're going to have a very big table to work out what's normal and what's not normal. But I think that it's a very valid point, and it's something that has to be taken into account when doing the analysis.
Thank you. Yes.
So I'll just answer that question, Sandeep. So one of the reasons that, okay, sorry. So sorry, so one of the reasons that this was made 10 plus 5 plus many other things is one is the time taken for a manometry. People were used to 10 wet swallows, which took like 10 minutes and finish it off. But when you do all these maneuvers, it works out to about 30 to 40 minutes. So that's one. Second thing, the volume of fluid that you give is excessive when you keep on increasing the number of swallows. So what I usually tell people that if you are going to leave it in the hands of the technician or the nurse to do the full manometry and show you the tracing, there's a very high chance that the protocol was not followed or there were some things that went wrong. It's better to be kind of aware of what's going on. And then if you see that your 10 wet swallows are showing an EGJ and the 5 wet swallows in the sitting position are showing normal, then this is more likely to be normal. And the same thing is true for the IEMs. Yeah. Well, that's.
No, I wasn't going to say anything.
Okay, sorry. Okay. Next.
Yeah, and another
Actually, I would just add one thing, which is that, as Shobna said, if you give people who don't perhaps have the understanding that we do of the importance of the study, and they may not recognise when you need to do the extra tests.
Right.
And that would either mean that the patient needs to come back, and that's why it's important to either have people who really understand the physiology, or in many cases to be there yourself so that you can see the study going on, because that's going to be the most efficient way to do it. You can work out when you have enough information to make your diagnosis. Otherwise, you're going to have to either do everything or finish up with patients coming back.
And another regarding the ineffective esophageal motility, as you have suggested, the Chicago has evaluated in evolution, and now the criteria have become more stringent. But what we find in clinical practice, even if you have an ineffective esophageal motility and if you do an impedance, most of the patient have the normal bolus clearances. So I think probably the ineffective esophageal motility criteria also should be should be taken with an impedance. What I feel.
Yeah, I think that is absolutely correct, because eventually what matters is the bolus transit. You need to have a bolus transit, whatever comes up in the manometry, right? That is the eventual aim. So Chicago has been trying, I think, being more, stringent with IEM, because initially it was diagnosed as a minor disorder of peristalsis. Now they want to fit it into the realms of major disorder, where it actually matters clinically. So I think it is still a work in evolution, and maybe the future studies based on impedance, when impedance is used as a part of Chicago, maybe the things might change.
Many of our patients are on antihypertensives and on nitrates. So, do these medications needs to be discontinued before doing esophageal manometry?
So nitrates, if you stop them only in the morning, that's fine. Okay, it doesn't really matter that much. Nitrates only cause the relaxation of the LES and will take away your pseudoechalasias, etc. But in general, we tell the patients, do not stop any medication. Take them except for your anti-diabetics, which is, they should not take it before the procedure, because then they are fasting for a long time and that will be a problem. The only thing that you need to do is ask a patient for a history of opiates. So opiates are the ones that will really have a problem with manometry. The second thing is some drugs that are used in urology are the ones that can cause an elevated LES pressure, and they can cause dysphagia. So you look at the history of the drugs and check whether any of these can affect esophageal function.
This is Dr. Salukhe from Pune. I have two questions. One is that initially in the first few years, we used to have a lot of literature on transitional zone melding, and there would be a transitional zone gap. And now it's all lost in this ineffective esophageal motility. Is it relevant anymore? Upper esophageal dysphasias and a large transitional zone defect.
So first is that transition zone is normal. So the transition zone is the zone where the skeletal and the smooth muscles meet. It can be anywhere from 1 centimeter to 5 centimeters. So the beginning of the DCI measurement is at the level of the smooth muscle. Okay, so if there is a very large gap, that may be a component of ineffective motility rather than just a large transition zone. And that is where the impedance comes in. And Chicago flow currently does not have impedance as one of its parameters, and that is why I did not cover it. I'm sure the other speakers will come back and cover it.
Just one more question is at the other end, that in patients who are having reflux, would it make a difference to demonstrate laxity if you do the study on a full stomach? We always do it on an empty stomach.
So one of the disadvantages of a full stomach is that the patient might start vomiting, because when you're putting in the catheter, it's a lot of gag, and if a patient has a low LES pressure, they're likely to just bring out everything. So that's going to be very unpleasant more than anything else.
Okay.
The second thing is that I demonstrated the straight leg raise test, and that actually mimics an increase in intra-abdominal pressure to show what is happening to the LES. It's another challenge, and it's so easy to do. There is really no need of doing anything much.
Thank you.
Only one question per person.
Hello, I'm Dr. Gaurav from Mumbai. Great talk, ma'am, and Dr. Shriyari and Dr. Jeff. My question is, we see a lot of patients with GER and IEM, and on MRS, they have got a very poor contractile reserve. What is the best option that we have in such scenarios, number one? And does EGJ-CI, your contractile index, the morphology of your EGJ, help you assess the plan of action? So a patient has got a type 3 EGJ-CI less than 10, very high risk of reflux, poor contractile reserve. Do you offer them, what kind of treatment would you offer?
So coming to the first question, that your augmentation is poor in such cases, the only connotation that it tells us that you can go ahead with a 360 degree fundoplication. So otherwise, you'll manage all these patients as you manage as a typical GRD patient. Start with lifestyle, medications, and eventually surgery if required. The EGJ-CI tells us about how good the EGJ is, how robust it is, and if the contractile integral is less, then obviously surgery is a valid choice in such cases.
Thank you.
I'm Dr. Sakshi. I'm a pediatric gastroenterologist. Ma'am, my question is for you. We are using solid state catheter in our institute, and I usually observe that when I'm doing esophageal manometry on kids, most of the time I'm doing in a sitting position only, and I usually find IRP always more than 16, 17, maybe more than 20, 21, 22 with normal peristalsis, and always confused what to do. I mean, should I always go for a barium study, time barium in all these patients, or
So first of all, which machine are you using?
MMS?
Okay, so the MMS cutoff is not 15. So the LES relaxation IRP cutoff for MMS is, I think, 18. So check that first.
Yes.
Second thing, are your patients crying intermittently?
No.
If they're children, if they're crying, then they automatically contracting their abdomen, and that might be pushing the LES pressure up. So look at these things before you start making diagnosis of EGG obstructions. And yes, a barium will help, but is the child having dysphagia? If they're older children, they can describe dysphagia, or they say that there is a feeding problem or there's regurgitation. But if the patient doesn't have that, just hold on before you give any definitive treatment, which means either surgical or endoscopic. Medical management is always okay.
Are there any comments from the chairpersons, and then we'll close the discussion here?
One question from chairperson. Yeah. I would like to ask one question. Sometimes the patient is sent to motility lab immediately after endoscopy. So how much bearing will that?
I didn't get you.
Sometimes the patient is sent to motility lab immediately after endoscopy. So how much bearing will that have on manometry finding, and what should be the ideal time gap?
Sorry, I didn't catch that question. Manometry after endoscopy.
Immediately after endoscopy.
Oh, okay. We actually do manometries after endoscopy because we have the odd patient where we have to place it endoscopically, and I have to say that most of those patients have abnormal manometry, so it's a bit hard to know how long it would take to get your normal metrics back. But I would say that we do it pretty much as soon as the patient wakes up, and it doesn't cause us any problems with making a diagnosis, usually because it's quite abnormal already. And I think it probably also depends to some extent on what anaesthesia, if anything, the patient has had. Often our patients won't have very much anaesthesia because the anaesthetists are concerned that they've got a full esophagus. And so I think it really doesn't, we don't delay things. We get them recovered from endoscopy, and we take them straight down and do the manometry, or sometimes do it in recovery, and it hasn't caused us any trouble.
I think we'll have to close this session here.
Just a quick comment to that. Flip is done during endoscopy. And people have commented on it that if the drugs that we give during anesthesia, they might affect it. One of the drugs that does do that is fentanyl. Fentanyl can cause spasm. The effect wears off in about half an hour to 45 minutes, which is the usual time taken from the endoscopy room to the manometry room. So it should not cause a problem.
We have to close the session. You can take your questions during the tea time. Thank you all the three speakers. Thank you chairpersons and my co-moderator for this wonderful session, and then we move into next. Thank you very much.